Another case, a 45-year-old female complains of breathlessness and fever. This is taken in December 1st, 2004. Diffuse interstitial changes, but it is not only interstitial. They are coalesced in the lower zones. The transverse fissure is thickened and a homogeneous opacity in the lower zones, both interstitial and alveolar opacities. 2 weeks later, most of it is cleared. Today, in this picture, it looks like a nodular, miliary, almost simulating miliary tuberculosis. But then tuberculosis does not manifest with multiple alveolar homogeneous opacities. Only in the terminal stage. Consumptive pneumonia, they used to call it, but not this process. Pneumocystis Kerini, a common opportunistic infection in patients with impaired defense. Even without immunodeficiency, one can get these Pneumocystis Kerini. Radiologically, a spectrum of findings are seen. It may simulate pulmonary edema, pulmonary hemorrhage, good Pasteur's disease, for example, bronchopneumonia, patchy opacities, alveolar proteinosis, diffuse bilateral homogeneous shadows, respiratory distress syndrome, bronchoalveolar cell carcinoma. Earlier we have mentioned the alveolar opacities. Here the patient had flu, admitted, and bilateral, symmetrical, homogeneous opacities. In fact, we could see the air bronchogram also. That indicates it's all consolidated lungs, respiratory distress syndrome, a complication of flu. A 51-year-old woman complains of cough and breathlessness. As you see, the pattern is today most of the films belongs to the chest. Another PAV of the chest, bilateral homogeneous patchy opacities. Almost looking like aspiration pneumonia or bronchopneumonia, bibasal. And you could see the CT. Again, lower zones are more prominent than the rest of the lung. Similar changes were also observed in prone scan. See, occasionally in a supine scan, you may say because of the gravity, the lower lobes may show some increase of bronchoscopal markings. But in the prone scan also, they are present. That means it's a constant finding. Excluding gravitational increase in the density, and the regions correspond to early interstitial pneumonitis. There are 5 or 6 types of interstitial pneumonitis, acute and chronic. Again, in prone position, predominant disease pattern, subpleural region of increased density in the posterior segment of bilateral, lower lobe with reticulations in supine and prone scans. That is a common finding that we see. Diagnosis, early interstitial pneumonitis. Due to what? Notice the dilated esophagus, which occurs in progressive systemic sclerosis or scleroderma. Actually, that much of dilatation you can see in normal patients also, and that nervous and aerophagic. One thing I have to mention when you are talking about scleroderma, not only it is the submucosal fibrosis in the skin, it also occurs in the lungs. That's why you get interstitial type of pattern. Same thing occurs in the gut also, particularly in the esophagus. The so-called KREST syndrome, namely calcinosis, Raynaud's phenomenon clinically, E, esophageal motility, S, skin changes, T, telangiectasia. So CREST, calcinosis, Raynaud's phenomenon, esophageal dysmotility. Here you have saw just the dilatation of the esophagus. Skin changes, thickening of the skin. In fact, sometimes you may get calcification subcutaneously and telangiectasis. Next case is 50-year-old male complains of pain in right chest. In the first looks as if it's pleural effusion only. But then with that massive, it's not a small pleural effusion. Effusion, why is the mediastinum and the heart in the same place? There is no fibrosis. There is no atelectasis that we could see. CT. a solid lobulated mass in the right pleura. Why pleura? There are no air bronchograms or anything. It is in the pleura, abutting the pleura. The convex margin is abutting the pleura. Some interstitial changes are there in the lungs also, of course. Again, lobulated pleural mass with a homogeneous type of density. It may be involved in the pericardium also. Pleural mesothelium, classical presentation of pleural mesothelium. The important finding is, first you identify there is a pleural lesion. It is not pleural effusion or an encapsulated empyema, because there is no encapsulation as such, but occasionally it may simulate a pleural mesothelium. And then non-shift, in spite of the so-called effusion and empyema, there is no shift in the mediastinum end. Pleural mesothelioma could be benign localized, where it may simulate encapsulated empyema or even a lung mass. Diffuse, lobulated, even malignant mesothelioma could be localized too, and it could be diffuse. In most of the cases, history of exposure to asbestos dust directly or indirectly. Asbestos bodies can be restored from sputum if you examine properly. And calcification of the pleura is most important in radiological finding in asbestos. This proved to be a benign mesothelioma, although there is no history of exposure to asbestosis. Another case, 25-year-old female complains of pain in the left chest. A smooth, ovoid, huge mass in the left hemithorax. Is it abutting the lateral margin of the thorax? Yes. But the major diameter is not on the pleural side. And of course, underlying ribs you can't really see on just this PA view of the chest. Lateral view, again, the maximum diameter appears to be on the thoracic side, but at the same time, there are acute angles. Penetrated view shows some calcific rim to this. Not only that, if you look carefully and count the ribs, the fifth rib is eroded, thinned out. That means either the mass is in the pleura, thinning the rib, or it may be in the lung also. We have seen some of the lungs, huge masses eroding the ribs, sometimes destroying the ribs too. In these cases, CT is essential to find out whether it's pleural, parenchymal, or extrapleural, namely in the bone or in the skin and subcutaneous tissues. You see that mass contains lots of bony spicules and septae, and fluid levels also. The rib is thinned out, aneurysmal bone cyst. Again, I'll show you. Look carefully. Multiple bony septae with lucent areas which contain blood. And then fluid levels, if you look carefully, indicates it must be an aneurysmal bone cyst arising from the rib. And then when we are talking about fluid levels, you may see in other conditions also, such as telangiectatic osteosarcoma. But then if you look at the ribs, they are thinned out, not really destroyed, and there is no new bone production. So we do not think of malignancy. And of course, CT proved it is an aneurysmal bone cyst. 27-year-old woman complains of pain in the left chest. Somehow, most of the films seem to be belonging to the women, but it is just incidental. Notice a rounded so-called coin shadow. See, in the description of lung nodules, you can get micronodules, miliary nodules, reticulonodular appearance, and then coin lesions, and then masses. Mass should be more than 3 centimeters. A coin lesion may vary between 1 to 3 centimeters. Less than 1 centimeter, nodule. Less than, say, 5 millimeters, you can find a micronodule or miliary nodules. Anyway, there is a coin shadow. And again, conventional radiology is so important that you have to see all the structures that are exposed, namely the soft tissues, the bones, the diaphragm, infradiaphragmatic region, clavicles, shoulders, if they are included, sometimes in the neck also, if it is included. Anyway, one of the ribs in the left mid-zone is thinned out again. That means this lesion is located posteriorly. A cone view, notice the erosion of the rib. Notice the ovoid appearance, not so round like a coin, ovoid appearance of the soft tissue mass. And there are no calcifications. Ultrasound, homogeneous, it's not cystic, monotonous type of appearance, solid structure. CT. Notice in the CT, and the film on the right side looks like an extrapleural mass, whereas here another section is rounded, still oval, and there is some pleural extension. Neurofibroma arising from the intercostal nerve. That's how it is eroding the inferior portion of the upper rib, because intercostal nerves run along the inferior portion of the ribs. Sir William Osler once said regarding medicine, it is a science of uncertainty. Although we call it scientific methods of diagnosis, sometimes it is uncertain. And an art of probability. You have to think of the differential diagnosis. Same thing in radiology also. Think of the several entities and come to a conclusion in order of priority. This time it is a 27-year-old male complains of pain on the back of the right chest. This is more or less a cone view to help out because the left chest and left lung are normal. The right dome of the diaphragm is smooth, no doubt, but if you look carefully, there is a septum-like thing in the middle. That's not unusual. Several leaves of the diaphragm produce scalloped appearance. So what is the diagnosis? Obviously, it is a posterior mediastinal mass. And what are the posterior mediastinal masses? In the right cardiopharyngeal angle, anterior we know, pleuropericardial cyst, herniation of the foramen Morgagni. Middle also we know, occasionally bronchogenic cyst and enteric cyst. Posterior mediastinum, again generally, neurogenic masses. In the lateral view, the shape is different. There is no erosion of the intervertebral foramina or the body of the vertebra. Shape is a little reniform, so immediately it would strike you, it must be a kidney. And how do you confirm? Do an intravenous pyelogram, you see the calyces, pelvis, and must be a kidney. Intrathoracic kidney. During development, it has not descended down and it is still stayed in the part of it in the thoracic area. 6-year-old boy has pain in the chest and cough for 4 months. Since tuberculosis is so common, progressive primary complex or perifocal infiltrate, they treated it as TB, but no response. At the time, his friend has got an ultrasound machine and he said he will see. There is a cyst or a solid. And then an ultrasound, you find multiple calcific densities with shadowing. Then CT. What is the significance of using CT? Well, it is the fastest way of making a diagnosis. If you consider everything, it is economical and least risky, very little radiation. No interference, no intervention. CT, again, there is a big mass in the right paravertebral area. But then one principle you have to remember. If you see this, how can you say it is posterior mediastinal? It is extending all the way to the anterior thoracic cage. But you have to know the epicenter, and the calcific densities are more pronounced in the posterior area. And in the lateral view also, it is in the upper lobe area, posterior mediastinum, but extending all the way anteriorly, calcific densities. neurogenic mass with ossification or calcification in a child. Neuroblastoma is the first diagnosis. Ganglioneuroma usually is oblong along the paravertebral area. Neurofibroma or a schwannoma. Meningocele you have seen in the lateral thoracic meningocele in a neurofibromatosis, but this is solid with calcifications and ossifications, classical of neuroblastoma. It arises from the neural crest cells. Neuroblastoma, 40% of the time it could see in the adrenals, 25% extra-adrenal area, but in the abdomen. Posterior mediastinum, 15%. It may also arise from the neck, 5%, in pelvis, around the bladder area, about 5%. 55-year-old with symptoms of chest pain. The heart looks peculiar, the cardiac shadow. It's lobulated. The pulmonary artery segment looks bigger, left atrial appendix, but at the same time, the space between the aorta and the pulmonary arterial segment is maintained, aortopulmonary angle. So it cannot be just the pulmonary artery. A penetrative view shows that there is a mass, retrocardiac mass, lobulated both on the right side and left side, and producing an appearance that as if it's a cardiac shadow in the PAV of the chest. The patient had neurological symptoms, so they did a myelogram in those days. Now, today myelogram is very, very rarely done because of the MRI. And if you see, there is an obstruction to the flow of the contrast at the level of D11. That means whatever the mass is, it's involving extending to the spinal canal. This is Cooley's anemia with extramedullary hemoptysis in the retrocardiac area, extending into the spinal canal. Extramedullary hemoptysis from the vertebrae, as though the marrow is squeezed out from the vertebrae, and develops extramedullary hemoptysis in the nerves, etc., and the soft tissues. 30-year-old patient comes with history of hemoptysis. There are several causes of hemoptysis, and then you have to know, is it spitting of blood, massive hemoptysis, moderate hemoptysis? Is it acute? Is it chronic? PAV of the chest. Again, you notice a density, but above the density, there is a lucency, an arc-like lucency, so-called meniscus sign. As soon as somebody mentions meniscus sign, you think of a fungus ball. But there is no history of chronic tuberculosis. Close-up view, again a meniscus sign, and the lower portion is solid and so-called tit sign. There is a over opacity in the dependent portion. That is an indication of a hydatid cyst. Somebody from India has described a tit sign, that is, you see an oval opacity, sometimes rounded, but if you look inferiorly as though it is gravity, by gravity, it assumes an oval opacity, oval contour. In the differential diagnosis, meniscus sign, fungus ball in any cavity, tuberculosis or otherwise, even sarcoidosis, in Ebola, you can get a fungus ball, infected Ebola. Ruptured hydatid cyst, gangrene of the lung, there is no parenchymal pneumonitis and gangrene, but you can get carcinoma of the lung sometimes, and Rasmussen aneurysm. It is an aneurysm in a tuberculous cavity because the invasion of the granulomatous tissue into the vessel, it produces an aneurysm. This proved to be a diagnosis of ruptured hydatid cyst. How can we tell whether hydatid cyst? Well, there are no other infiltrates in the lung, so tuberculosis can be ruled out. Carcinoma of the lung, although this is an eccentric cavity, the superior margin is so thin. And then, as I said, a tit sign in the opacity, in the inferior portion, is diagnostic of hydatid cyst. 45-year-old person complaining of chest pain. Again, you find a nice, well-defined homogeneous opacity in the left paracardiac area, left para-aortic area rather, and on the right side, ascending in a artery also shows prominence as if there is a dilatation. The first thing is you think of an aortic aneurysm. And since we got the MRI for the first time in South India, it was handy. We wanted to see, lo and behold, you can see the aortic aneurysm. You don't have to do an angiography or ultrasonography and all that. You see the clot also. Layers of clot in the lateral view. Aneurysm of the aorta with a clot. 37-year-old male presented with backache, BACK, it's not American English, right? Backache and weakness in both lower limbs. So they took a cone view of the thoracolumbar spine. And if you see the D10, there are lucencies. The pedicle, particularly on the right side, is not visualized properly. There is compression of the vertebrae. Could be hemangioma, osteolytic metastasis, giant cell tumor, although rare, and plasmacytoma. Lytic changes in D10. Differential diagnosis, infection, but there is no paraorbital soft tissue swelling. The interorbital spaces are well maintained. Granuloma, eosinophilic granuloma, possible. Hemangioma, there are no typical vertical striations or jail bar appearance. But in a cavernous type of hemangioma, you don't have to see that. Giant cell tumor, although rare, could occur in the vertebra also. Plasmacytoma, localized. Paget disease, a lytic type of Paget disease. But the vertebra is not enlarged. That is the major finding in lytic Paget disease. And there should be a picture frame type of appearance. The cortex is thickened but well maintained. So, they have taken CT, could be still hemangioma, and part of the vertebra is also involved, extending posteriorly. Same thing, same appearance. CT scan, it is a hot spot. It doesn't tell us anything, but they haven't taken a vascular phase. Again, showing the same appearance. Then MRI. There are several flow-voiding changes there, signals. And hypervascularity is vascular brush from a selective angiography, dorsal branch of the artery, intercostal artery. Embolism was done thinking it is an hemangioma, any vascular type of tumor. It's not an aneurysm bone cyst, it's not expanding that much. With PVA particles. It's occluded. And not satisfied with this, they did a laminectomy. D9, with excision of right pedicle, the removal of lesion with transpedicular screw fixation and a rod replacement to prevent further collapse. That's the picture. Conventional radiology. Histopathology section shows necrotic bony spicules admixed with sheets of plasma cells along with other chronic inflammatory infiltrates with areas of hemorrhage. Say could it be chronic osteomyelitis, they said. Advised bone marrow biopsy to rule out plasma cell dyscrasia. And then patient was all right for a year. He came with spastic paraparesis, loss of bowel and bladder sensations in July 2005. Again an MRI was done. It is little more aggressive at this time, the lesion extending posteriorly. Again the same thing, little more aggressive year after. Again surgery, posterolateral thoracotomy and D9 vertebrectomy, anterior spinal fixation was done. Solitary plasmacytoma, it appears to be histopathology. Age 50 to 70 decade, axial skeleton 25 to 60%, thoracolumbar spine, common, pelvis, ribs, sternum, skull, femur. Radiologically, a little expanding lytic lesion. What I want to impress on you is the MRI of a plasmacytoma, mini brain sign in plasmacytoma. It has been described in AJR 2001. And age again is common from the literature, mini brain sign. type of cortical thickenings unique to plasmacytoma. What they have explained, why this appearance, mini brain appearance, which is not seen in other primary or secondary spine lesions, due to less aggressive, slow growing. It has been running for 2 years compared with other tumors that destroy the bone. The CT appearance of Paget disease and hemangioma is also reported to have thickening of the trabeculae, residual trabeculae. However, the appearance of hemangioma and Paget disease on MR imaging does not produce mini brain appearance. That's the point that I want to express. Mini brain appearance in an expansile lesion of the vertebral body is sufficiently pathognomonic of solitary plasmacytoma. So that is the varied. Of course, we have confined to the thorax, first majorly the lungs, and then pleura, and then the mediastinal structures, intercostal structures, ultimately